Danny's just joined us. Today's topic is going to be fairly brief because there's only 1, 2, 3, 4, 5, 6 of us, and we're going to give Santi 20 minutes of free reign to tell us everything he thinks we need to know about anal fistula and abscess. Santi, are you ready to go?
Yeah, I am.
Okay, Santi is a colorectal surgeon from Newcastle. He's a DAISY member. He went with me to Solomon Islands, Munda. He spent a week with me stranded in Taro, and he spent some time at Cleveland and St. Mark's Hospital in London, and has a fair bit of experience on the topic of anal fistula. So he's going to give look, it's a fairly didactic talk. I apologise, and if you have questions, write them down and save them for the end. Okay, so I'm just going to open up his PowerPoint presentation, and I'm going to share the screen with you. 1 second. Okay, slideshow from current slide. Okay, let's hope this works.
How come we can't see you, Gary?
I don't know. I've got no idea.
We've got the San Francisco Bridge.
I know. I'm gay proud, but I'm not gay. Right. Okay, let's share the screen. All right, go, Santi. I'm timing you, 20 minutes.
Well, thank you, Gary. Thanks for others for attending this session. I'm going to briefly discuss about anal abscess and fistula, and both conditions are related. So I'll start with the next slide.
Sorry. Hang on a sec. Okay.
Now, to understand the anal abscess and fistula, we need to understand the anatomy. The anatomy of anal canal is divided into anatomical anal canal and surgical anal canal, which means that the hindguard comes and joins the proctidium at the level of dentate line. The nerve supply and the blood supply is totally different. So when you look at the anatomy, you have mucosa, submucosa, and internal sphincter, and then longitudinal muscle and external sphincter. All right. Now, anal crypts are very important. It starts at the dentate line, and it has a sort of it's got what do you call it? It spreads in between the internal sphincter, up and down, and also through the transverse muscle. Not transverse, external sphincter, which means that this can cause to anal fistula and abscess. Now, length of the anal canal is longer and stronger in male than females. To mention that the anal canal is a little shorter anteriorly in the female. Now, this is a diagrammatic picture of anatomy. The blue color is internal sphincter, and that's a circular muscle, and the red one is a longitudinal muscle, and the green one is external sphincter. The pictures on the right-hand side is ultrasound. The central dark area is the probe, ultrasound probe. Just outside the white ring is submucosa, and the darker ring is about 2 to 3 millimeter in diameter, and that is internal sphincter. The white color outside is the external sphincter, and further out is a little bit vaguely seen. That's a pupa rectalis, which is actually absent on the front. And of course, below that is a MRI using endocoil. Now, anal gland starts at the dentate line, and it's got blind tracts, which goes up and down in the intersphincteric space, and also travels through the external sphincter. Now, anal abscess, go back to it. Anal abscess is mainly, most of the anal abscess related to the infection of the blocked ducts of the anal glands. Most common problem is the infection and the Crohn's disease. Next one I would say is infected chronic anal fissure, which cause post-anal space abscess along with the fistula. Other one are foreign body and infection and malignancy. Now, the abscess types are subcutaneous, intersphincteric, extrasphincteric, ischiorectal abscess, and horseshoe abscess. Now, the picture shows all the levels of abscess. How to make a diagnosis? It's very important to take a history. You have to ask the person whether they had any previous episodes. Diabetes is important, particularly if they are a type 1 diabetic. The abscess needs to be drained fairly quickly, otherwise they become very septic. We need to know about the sphincter function, whether they have any passive or active incontinence. Also need to know whether they had previous surgery and other GI symptoms such as irritable bowel syndrome and etc. Physical diagnosis based on a physical inspection examination. When you look at it, look for inflammation, induration, swelling, and fluctuation. These are the abscess: perianal abscess, intersphincteric abscess, ischiorectal abscess, and supraelevator abscess. Now, what are the symptoms? If it's a superficial abscess, perineal pain and swelling and fluctuant swelling is a common finding. Fever is not common. Deeper abscess usually have perineal and gluteal pain. No obvious signs, even if it's a large ischiorectal abscess, extralevator abscess. One thing I would like to caution is intersphincteric abscess. The patient will have extreme pain, but when you examine them, when you see them, you don't see any signs of it. So no obvious external signs. Pain is out of proportion to the finding. The patient, if you examine him under anesthesia or even in the office, you should be able to feel a swelling in the anal canal. So what are the investigation which you do? So for a superficial abscess, it's a clinical diagnosis, no need for investigation. But for recurrent abscess and fistula, complex fistula, Crohn's related, we often do an ultrasound, CT scan, MRI scan. In Solomon Island and PNG, fistulography for a patient with the anal abscess of a great help. Diagnosis rate is about 100% when you use the combination of ultrasound and MRI scan. Ultrasound is also helps to identify the abscess and also helps to identify any sphincter deficiency or weakness, either internal sphincter or external sphincter. Now, management of abscess, it's a prompt diagnosis and drainage is utmost importance. When you drain an abscess, you make a linear incision close to the anal canal to reduce the length fistula if it has to develop in the future. Packing, we do not recommend it, mainly because of increase in pain and delays in healing. Antibiotics are not necessary unless the patient is immunocompromised or have systemic symptoms. So method of drainage in different type of abscesses, as the picture shows, if it is an intersphincteric or proximal extension of it, best to drain it into the anus or the rectum to prevent fistula formation, whereas ischiorectal or supraelevator extension, you drain them externally. When you, even though there will be a lot of swelling in the ischiorectal area, sometimes it's hard to find where the abscess cavity is. So you could explore it with a large bore needle until you get an aspiration of pus, then you can drain on that side. So management of abscess, when would I do a primary fistulotomy? Should we ever do it? The reason why you shouldn't do it, because 50% of abscess doesn't relate to a fistula. Therefore, there's no need to do it. But if you explore looking for a fistula, then there is a possibility of false passage due to probing. So if you do a simple drainage, wait and watch. If they develop a fistula, then they will keep coming back saying they have recurrent swelling almost on the same side, and they complain of persistent discharge. So when would I do a primary fistulotomy? When the fistula is obvious. And another clue to finding an internal opening is if you press on the abscess, particularly in the perianal abscess, you can see the pus extruding through the internal opening. That confirms that there is a fistula and it can be divided. The Hanley procedure is meant to drain very large Hershey abscess. You make an incision in the postanal space with the minimum sphincterotomy, and then have a counter lateral incision to drain the abscess. You can place the drain for some time until the wound heals, and the midline wound may result in a fistula, and this can be taken care of at a later date. We're coming back to fistula, anal fistula. This is a Goodsall's rule. If you imagine a transverse line, transverse horizontal line on the perineum, the anal canal, if the fistula is anterior, it's always in a direct entry into the anal canal. If it is posterior, it often have a curved track. And we also have to note that almost 80–90% of internal opening is in the midline. There is exception to the rule if it is more than 3 centimeters long, or if it's due to Crohn's disease. Goodsall's rules may not apply. So what is fistula? Fistula is a tract connecting the perianal skin to the anal canal. About 30–70% of patients with abscess present with the fistula. So common type of fistula is intersphincteric and transsphincteric. The picture on the right-hand side would show you exactly what it is. Suprasphincteric and extrasphincteric are less common, but some of them are iatrogenic. So the classification is simple and complex. Simple fistula is an intersphincteric fistula, or fistula tract involves less than 30% of the sphincter. That's the external sphincter. Complex fistula, if the sphincter is affected more than 30%. Suprasphincteric, extrasphincteric, horseshoe fistula, fistula associated with Crohn's disease, radiation, malignancy, and pre-existing incontinence. So how do you make the diagnosis? Patient history is very important. you ask for previous fistula surgery, sphincter function in relation to incontinence, GI symptoms such as diarrhea or constipation, irritable bowel syndrome, and history of Crohn's disease. Investigations, bedside examination to identify the abscess, and may even be able to feel the fistula internally with a gloved finger. Examination under anesthesia will can help you to gently probe and find the fistula tract. Anal ultrasound, about 85% successful in finding the fistula along with the sphincter defect or deficiency. When you do an anal ultrasound, sometimes we inject hydrogen peroxide, and that will delineate the fistula tract as well as the abscess cavity. MRI scan is helpful in complex fistula, and as I said earlier, fistulography is greatly helpful, particularly in Solomon Island and Papua New Guinea. This picture on the right hand side, thanks to Gary, and that show very complex anal fistula. This is done by the radiologist with a catheter in the external opening and inject dye and a plain X-ray. So management of fistula is a balancing act between recurrence and incontinence. We want to prevent the recurrence and make the fistula heal with minimum risk of incontinence. Now, the picture on the right-hand side, there are a couple of devices. The one on the top is called Lockhart memory probes. There are a set of 4 of them. The lower one is very helpful. It's a curved instrument. It's got a little groove on it, along with the eyelet on the tip. So if you find a fistula, then you may be able to thread proline suture through the gutter of the instrument, bring it through the internal opening, and tie a black silk or vessel loop and tie around the fistula tract. And the picture on the left hand side shows different kind of materials you can use for ceton suture. Now, for a low fistula, it's ideal to do a primary fistulotomy. The healing rate is about 90%. I must understand that there is a risk up to 40% of minor impairment. The patient need to be warned. This could be in a form of minor soiling or flatus incontinence. This is mainly due to the internal sphincter dysfunction. The risk factors of impairment is due to previous history of sphincter dysfunction, previous anal surgery, female patient in particular, and complex fistula. Ceton suture comes to help you in various situations. The picture you see on the right hand side, the instrument is gone through the internal opening to the external opening, and piece of vessel soup brought out and tied loosely around the fistula tract. The ceton can be used as a loose ceton or a cutting ceton. Loose ceton is mainly used as a drainage and as a staging for definitive surgery, and as well as Crohn's disease. So when you're exploring the fistula, and if you think that the fistula is complex, it's got higher portion of the sphincter muscle involved, I would just use a loose ceton. My experience in the past is when you do that, there is a tendency for the ceton suture to migrate further distally, and you examine them at a later time. The fistula becomes very simple, so you can do a fistulotomy. Cutting ceton is the other way of dealing with it. It is after applying the ceton, you gradually tighten the ceton either in the office or under anesthetic, depending on the patient's circumstance. And this tightens the muscle, divide the muscle when there is a fibrosis happening in the proximal proximal end. So when the fistulotomy completed by cutting seton, the sphincter doesn't spring back, but it's held by the fibrosis. The healing is up to about 90%, but there is up to 12 or higher level of fecal incontinence. We have to be aware of that. So fistula management, there are other things available. This may not be available in Solomon Islands, mainly because of the cost, but I'll mention it for completion's sake. Fistula plug, you see on the diagram where the plug is brought through the internal ring to the external ring, through the internal opening to external opening, and switch it to the internal opening. Now it is made of acellular collagen matrix inserted through the fistula tract and switch it to the internal opening, and the internal opening itself is so switch it to the internal sphincter, and the mucosa is closed over. The external opening itself is cured and left open. The success rate is about 50%. Failure often happens due to sepsis, dislodgement of the plug. If the fistula is short, then it may not work. Of course, Crohn's disease and rectovaginal fistula and smoking. Now, next is a fibrin glue. This is injected through the external opening until you see it coming through the internal opening. And the success rate is quite variable, between 14 to 60%, and often fails due to lengthy tract and complex fistula. Now, why you bother using this device when the success rate is not very good? I would say I would use it because even though it's got moderate success, I have not done any damage to a sphincter muscle. So if I can afford it, I will use it. Okay, next one, you see, this is this can be learned and practiced at Solomon Island and PNG. Well, first one is a lift procedure, which means ligation of a fistula tract in the intersphincteric space. If you look at the picture on the right hand side, the probe is through the external opening into the internal opening. There is a dotted line which shows that is the intersphincteric space. So the incision is made on the intersphincteric space, and so before you do that, you place a seton and leave it for a number of months for the fistula tract to mature. And when you do the operation, make an incision on the intersphincteric space, you should be able to identify the fistula tract and divide them, and you close the internal opening, but leave the external opening. The healing rate is variable, about 60 to 90%. Failure is due to long tract, more than 3 centimeters, and I had previous fistula surgery. Some failures occur due to this. Sometimes intersphincteric part of the fistula might close up, and you will end up in the intersphincteric fistula, and this can be done as a simple fistulotomy. Next procedure is the endorectal flap procedure. The picture tells you that, shows you that you see the internal opening with the on a flap, which is excised, and then the internal opening is closed. If the internal opening in the muscle itself closed, and raise the flap using the mucosa, submucosa, and internal sphincter, and slide the flap down and suture it to the distal wound. Very complex procedure. We need some expertise, but you can learn this. The healing rate is about 60 to 8%. The failure can happen mainly due to Crohn's disease, and if we had a number of previous attempts, the failure is likely to happen. Previous radiation is another contraindication. If there is active proctitis, then this should not be done. Rectovaginal fistula which is ideal situation to do this. Malignancy is another cause. You shouldn't be doing this. Finally, I'll give you a tip I follow when I have done the fistulotomy in the past. The picture on the top shows an external opening, anteriorly leading straight into the anal canal, and posteriorly has a curved track. So if I'll probe the external opening very gently, if I get into the internal opening very easily, then I'll do a fistulotomy. In that situation, if I'm concerned that the external sphincter is high, the fistula is high, then I will use a ceton as a temporary measure. Now, if I can't probe into the internal opening, then I'll chase the granulation tissue. So I slowly cut along the probe until I come to the anal margin. And then you may be able to get into the internal opening. If we can't do it, I'll leave the procedure and then I'll come back at a later time. At that point, if there is a fistula, then the external opening would have moved close to the anal canal, and hopefully you have a second attempt at finding the fistula. With that, I'll finish up. Thank you.
Thanks, Santi. Appreciate that. So, yeah, Santi is also one of the founding members of the Colorectal Surgical Society of Australia and New Zealand. I forgot to mention that. So, yeah, that was a really complete talk on the management of fistula. And I think the Parkes classification from St. Mark's hasn't really changed much in the last 60, 70 years. It's still as relevant today as what it was back then. So, yeah, discussion. Can I guess the obvious thing is that MRI is not available, nor is CT. To be honest, it's overused, in my opinion, in Sydney. It's expected that we'll get an MRI for any patient with a recurrent fistula, but I think that the bedside examination and the examination under anaesthesia is the most important thing. What do you think, Rooney and Mike and Danny?
I agree with you, Gary. Santi, that was a great talk. Thank you so much. I think that the take-home message that I usually when I'm explaining this to patients is that the biggest priority is continence. At the end of the day, once you've got a ceton in, there's no rush to do anything. The patient is safe from future sepsis, and they can live with the ceton forever. And essentially, the longer the ceton is in, the less likely the next operation will not succeed. So the more likely it'll succeed, the longer you leave that ceton. So if you can put in a ceton and encourage that patient to live with it for as long as possible, that's the best outcome. When it comes to doing a definitive procedure, as Santi was saying, it's a balancing act between the risk of incontinence versus the risk of recurrence. And the key to success is the healing of the internal opening. Once the internal opening is healed, then problem solved. That's the end of it. Once the hole on the inside is gone, then they no longer have a source of sepsis and their problem is solved. Now, I tend to be very reluctant to do any degree of fistulotomy unless it's really, really shallow, because if you render a patient incontinent, that's for life. It's a really difficult thing for them to deal with. And in my opinion, if it was me, I'd rather have a fistula than be incontinent. So I tend to do a lot more non-sphincter dividing procedures, and my procedure of choice is the lift procedure, where you basically go in between the sphincter muscles, divide the fistula, and that essentially for me is like an insurance policy. The idea being the stitch on the inside is what's going to give them a cure. If that stitch of the internal opening heals, then their problem is solved. But if it doesn't work, and I quote them about 20% risk it's not going to work, then they end up with a much shallower fistula because I've divided the fistula in between the sphincters. Whereas when I used to do mucosal advancement flaps, if it doesn't work, they go back to square one. They get their original fistula back. So I think the take-home message from here is you can always just leave a seat on. That's quite reasonable. The success of the operation is all about the internal opening, and it's better to err on the side of caution and cut as little muscle as possible. They're my basic principles of fistula management.
Gary, can I add a couple more things on it?
Sure.
Well, when I mentioned the sit-on suture, I mean, I've been brought up in the 70s and the 80s, so I used Prolene suture, and patient often complained because Prolene irritates, particularly digging into the anal canal. So vessel loop has arrived much later, so it is softer material, you can use it. But I'm not sure about Solomon Island and the PNG, but I would recommend a black silk, thick black silk suture, which will be very helpful to create a track. Another procedure for a very high fistula is called a Mann's procedure. What you actually do is, this is for a high fistula, where you do is to find the fistula, and then you divide the mucosa and the internal sphincter, and then you isolate the external sphincter using a sit-on suture. And then this can be used as a cutting sit-on. So that's what I wanted to add up.
Yeah, thanks, Sandy. So Rooney and Michael, what's been your experience with fistulas? Are they very common?
Yeah, so I'll go first. Yeah, I do see roughly around 10 a year, and for the low ones, if they are sort of long term, I would do a just a primarily fistulectomy. For the higher ones, I've been using just a Prolene suture or silk suture as a sit-on suture, and just follow them up long term. But roughly around, so for this year, I've seen in OPD, I've seen about 10, but with depth of surgery, I think just 3. One sit-on placement and 2 primary fistulotomy for short tracks.
Okay, so that's not a huge volume. Perhaps it's a more common condition in Australia. And what is your approach, Mike, when you have an acute abscess? Do you go looking for the internal opening, or do you just drain the abscess and see how they go?
I would do it under a spinal and examine under spinal, and then if there is sort of obvious, I would just drain the abscess, especially with the diabetics early drainage. I don't routinely search for the internal openings, but
yep.
It's probably something I could search for now, having listened to this lecture.
Yeah, that's a standard approach. Yeah, I think the only thing I would add to Santi's talk is even the intersphincteric fistula can be complex if it's involving more than 50% of the internal sphincter. We tend to underestimate the value of the internal sphincter. So assessment of the internal sphincter can be difficult in a paralyzed, like in someone with a spinal or a general anesthetic, because you just can't appreciate the upper limit of the internal sphincter. So I think part of your bedside examination, as painful as it may be, is inserting a digital finger in and estimating what their anal sphincter contraction is like, and also estimating the length of their internal sphincter and the height of the internal opening in relation to that internal sphincter. And Santi's also quite rightly pointed out that an anterior fistula in a woman is also complex. Even if it's quite low, it can be, you just need to proceed with caution, because obviously the female anal canal is less developed, particularly at the front, anteriorly, and they have other changes that increase their risk of long-term incontinence that men don't have, such as obstetric trauma and menopausal changes.
So can I just ask, does anyone have any cool tricks if you put the probe in and you can't find the internal opening? Any cool tricks to find the internal opening?
Can you ask the question again, Danny?
I was just saying, does anyone have any tricks to help find the internal opening if you put the probe in and you can't find it?
Well, apart from what Santi's already mentioned, which is squeezing on the fistula tract, seeing if pus comes out. I think, Santi, did you also mention hydrogen peroxide?
Oh, that's for, yeah, we have used that too. No, that's for the fistula, not for the abscess.
Yeah, that's what Danny's talking about. You know, tricks for finding the internal opening where it's not obvious.
Well, squeezing in the abscess cavity. If you're going for a primary fistulotomy during drainage of abscess, first thing is to squeeze on it. The pus can come through the internal opening. Then you're confident that the internal opening is there. You can probe it. And again, depending on high or low, you do a fistulotomy or sit-on suture. And for a fistula tract, for external opening, you can inject the hydrogen peroxide. If they come through the internal opening, again, that helps you to find the tract. Won't use a methylene blue because it makes a big mess. Once you've done it, you've done. So these are the things which I have done in the past. Yeah.
Yeah, I've never done it, but I've heard propofol can be injected. It's a white, opaque fluid that allows, if you fill it up, you can see the dripping of white propofol come through the internal opening, but I've never done it personally. Rooney, do you have anything to add there? I think you need to unmute. Alrighty. Well, I think, Rooney, did you have anything you wanted to add? I think you need to unmute. I think I muted you because one of the phones was ringing. Anyway, while they're working out the mute section, thank you very much, Santi. I think we'll keep it short. It's not a big topic, and a good meeting can sometimes be a short meeting. Here we go. That's Jason. Yeah, I think we can hear you now. Hello?
Yeah, hello. Yeah, sorry.
That's right.
Hey. Hello?
Yeah.
Oh, yes. So I think thank you for that excellent presentation by Sandy and the contributions that that were given. I think we've learned a lot. I think it'd be great to share that presentation as well, and it's going to be on the website. Yeah.
So sorry, I was just letting Roshni in. What was that?
No, so the session is going to be on the website, isn't it?
Yes. It'll be recorded and put up on the website with some minor editing.
Okay. So excellent. So thank you very much for the presentation.
Okay. No worries.
Yeah, so I think here
Yep.
Yeah, so I think fistula is not uncommon here as well, and I think us generally we do fistulotomy or putting a sheet on if we think it's high. With regards to fistulography, do you do that when you suspect that it's going to be a complex fistula, or do you do that as a routine? And here I think we don't do the rectal ultrasound. Perhaps that's something which maybe we could encourage our radiology team to perhaps learn how to do it so that we can make use of them more.
Yeah, I think Santi's probably had more experience with fistulography than Danny or I have. I've never done it because we've always revert to MRI for a complex fistula. Here we basically do MRI with fat saturation images with gadolinium enhancement, and it's really quite amazing the pictures you can get. But Santi, have you used fistulography?
Yeah, I have the ancient times.
Right.
Yeah.
And the other thing, yeah. The other thing about endocoil ultrasound, Rooney, is that you need a special endocoil probe. So it may not be that your current ultrasound machine will allow for endoanal ultrasound.
All right.
But it's something we can sort of look for. I must admit, I find it really hard to interpret endoanal ultrasound. And, I wouldn't be confident of my endoanal ultrasound interpretation skills. I certainly wouldn't be trying to teach anyone how to do it. I would rely more on the clinical examination and examination under anaesthesia.
Okay, thank you.
All right, well, thanks, everyone. I'll send you the WhatsApp link for the next session. Thank you, everyone.
Thank you.
Thank you very much. Thank you.
Bye.